Now, I'm just about to introduce our first speaker, who is Professor Anushka Patel, Fellow of the Academy of Health and Medical Sciences, who is the Chief Executive Officer for the George Institute for Global Health. Anushka and I sort of have crossed paths in the past when I was working in association with the George Institute, interestingly in relation to our work in very remote Western Australia. Now, Professor Patel is an honorary cardiologist at Royal Prince Alfred Hospital and a Professor of Medicine at this university, the University of New South Wales. She is the chair of George Medicine, which is a spin-out company aiming to bring affordable cardiovascular preventative medicine to markets globally. Over the past 25 years, she has engaged in epidemiological, clinical research and implementation science, and has led the pivotal advanced trial in diabetes, which she may be talking to us about today. So, welcome.
Thanks very much, Liz, for that introduction, and Louise for your words. It's a real pleasure to be here and invited to share my story. And I too would like to start by acknowledging the medical people of the Eora Nation and pay my respects to elders past, present and emerging. So I'm not a clinician-scientist anymore. I've hung up my stethoscope as of 18 months ago. So that's part of my journey that I'll come to shortly. So I think people have many reasons, often multiple reasons for becoming a clinician or becoming a scientist. But I think we all seek to create, one of those reasons at least, is to create impact, whether it's for individuals or for society at large. I think being a clinician-scientist, and certainly for me, I've seen the advantage of being able to actually see the impact on patients in front of you, or hopefully from your research, maybe not right now, but maybe in the future, on populations and on society. While ultimately I think it's for others to judge, I think being a scientist has helped me be a better clinician, and vice versa. And I hope that a little bit of that might come up through my story. So this is where my adventure began. This is a publication in the journal Tubercle in 1959. So I'm not a 90-year-old who ages extremely well, but like all of us, we have a background and a context. And my father was a respiratory physician. I'm a third-generation born Ugandan. And my father didn't talk much about his clinical work in Uganda. He talked a little bit about it. But my earliest childhood memories are actually of him talking about being the officer in charge for the WHO MRC trials in tuberculosis treatments in East Africa. And he was very proud of that and the impact that had. We were then sent out of Uganda by Idi Amin, and we ended up in Far North Queensland. And my other earliest memory that I think has influenced my journey, this is a picture of Torres Strait Islands. I don't remember going there, but I do remember accompanying my father on some trips to communities in Far North Queensland in his role as the regional tuberculosis officer in charge. And I remember asking him, have we left Australia? I was a small child at that point, and really recognizing for the first time the quite large disparities we have in healthcare access, healthcare outcomes in this country. Roll on a decade or so, and I did my medical training at the University of Queensland, where in the 1980s, of course, was the emergence and the peak of the HIV/AIDS epidemic. And in my medical training, like all, did a subject in parasitology, and for reasons I still don't understand, I fell in love with the malaria parasite. This extraordinary organism that has plagued humanity for millennia. I have another interest in history, so this was really an interesting area for me. And I was convinced at the end of medical school that I was going to become an infectious diseases specialist. I was interested in global health. That all seemed to make sense. As in Queensland, we had an opportunity to do electives overseas, and I jumped at that opportunity to travel to Africa. I wanted to actually see if I could go to Uganda, to my place of birth, which I'd never been to. Couldn't quite get there, but got to Kenya and negotiated a period with the Kenyatta National Hospital Infectious Disease Unit. Turned up in day one and they said, sorry, you're going to be treating people with hypertension. And this was an extraordinary experience, not what I expected, but I also didn't expect lines of people, often young men, looking for treatment for high blood pressure. My job, and I don't think I actually knew how to take blood pressure very accurately as a fifth-year medical student, was for three-minute consultations, take the blood pressure, tell the doctor what the blood pressure was, and then usually he would write the prescription and the patient would head off, often without a word spoken. Also opened my eyes to the very large differences that we all know existed across health systems. So roll forward a few more years. I finished my medical training, internship, residency, moved to Sydney, and was a medical registrar at Royal Prince Alfred Hospital, where I remained for many, many years subsequently. And rotated into cardiology, and to my absolute shock and horror, I really enjoyed it. I felt like I was betraying myself and my cause in life. But this was an interesting time. This was a time when the overall mortality rates for coronary heart disease were declining, but we were still in that sort of upsweep of hospital presentations, often very sick people in the 50s and 60s, men and women, with acute coronary syndromes. It was an exciting time. I really enjoyed that excitement. But it was also a time when we had treatments. We actually were generating lots of evidence about new treatments that were highly effective in particularly the acute treatment of people with acute coronary syndromes, particularly ST elevation and myocardial infarction, but also preventive drugs. And the fact that you could actually see very sick patients and see improvements in very short term, but also long term, was for me a very interesting area. So I did end up training in cardiology, always with a bit of shame and guilt, but I did it nevertheless. And it was something I enjoyed tremendously. In the end, and during my training, for the first time, really got exposed to the type of research which I found extremely interesting. And it was really that research where I saw a short-term horizon to impact. Almost weekly, we would see journal articles producing the outcomes of large-scale clinical trials, or like this, systematic reviews of the evidence that then got translated into practice within a few years. This is an example of thrombolysis versus placebo or control in patients with ST elevation MI. And this was really the pivotal study that showed that you really had to get individuals treated within 12 hours to have any benefit. So at the end of my cardiology training, I was committed to a career in cardiovascular medicine, but also a research career, and I wanted to be a clinical trialist. I decided at that point I also wanted to travel again. I had the opportunity at that time from a family perspective, and I felt sure that I didn't want to start a PhD, or perhaps put another way, I wasn't sure that I wanted to do a PhD. So I decided to look for opportunities to get some exposure elsewhere in centers of excellence around cardiovascular epidemiology, and I ended up at Harvard. Did a master's degree in epidemiology at Harvard School of Public Health, but had incredible exposure through my supervisor at the Channing Laboratory to really then what was cutting-edge epidemiology, nurses' health study, which has really established some of the most important findings around risk factors for cardiometabolic conditions and many other studies. This was a time really where the training I got in quantitative epidemiological methods, I probably could have got just as good training anywhere in the world, including here in Australia. But it's not too many places in the world where one day you could be listening to a lecture in meta-analysis, and the next day you can hear Nelson Mandela visit and speak. So it was a fantastic experience. At the end of a couple of years there, I had secured an opportunity at Duke Clinical Research Institute in North Carolina to do a combined research and clinical job. And if that had come through, I probably wouldn't be here. There's a good chance I would have stayed in the US, where there was lots of both funding opportunities but ongoing clinical opportunities. But as often happened, life intervenes, and for personal reasons, I had to take a career break and return to Australia, family reasons. After a career interruption, about 6 months ago, I was very lucky to secure a role as a staff specialist back at Royal Prince Alfred Hospital. And at the same time, get a job as a research fellow at the NHMRC Clinical Trial Centre. Really, at that time, the premier institution in Australia for engaging in large-scale, multinational clinical trials in cardiovascular medicine, as well as oncology, which was really, at that stage, still my primary interest. I had the opportunity to engage in my first research project as in a leadership role, and led the first systematic review published around primary coronary angioplasty that was just emerging as a treatment alternative to thrombolysis. This was long before stents were available. And, again, producing evidence that was very quickly then being translated into practice. I also had the opportunity, as just one very small cog in a very big wheel, to get involved in multinational clinical trials in acute coronary syndromes, which again at that time I thought was going to be my future. This was the HERO 2 trial, which compared bivalirudin compared to placebo in patients with acute coronary syndromes undergoing interventions. And I learned an incredible amount around both the scientific but also the technical and logistical aspects of how do you do these very large research projects that often involve tens of thousands of patients in many countries around the world. But I also started to get, this was over a 2-year period, started to wonder, is this really what I do? This is really interesting stuff. It's good science. I've learned an incredible amount of I've learned a lot in terms of technical skills and the art of doing research, this type of research. But really, is doing trials that are going to show 1% difference in mortality when we've already got in-hospital mortality down to 5%, really going to push the needle? Is it something that's going to inspire me, motivate me? And the answer was increasingly no. And I was being pushed more towards an interest in prevention. And that was starting to happen in my clinical role too. I had 2 days a week in RPA, in hospital medicine, acute coronary syndromes, cath lab, but I was starting to develop an interest in preventive medicine and had the opportunity with some colleagues to help with the transition of the lipid clinic at RPA into a general cardiovascular preventive clinic. And my boss at the time, the head of the department of cardiology, who knew of my broader interests and knew of my global health interests, called me one day and said, look, I've heard something very interesting. There's this couple from New Zealand who've moved to Australia. They're establishing an Institute for International Health. But it's an institute that's focused on cardiovascular disease and other non-communicable diseases and injuries. So you might want to go and have a chat with them. So I did. I went and spoke to Professor Stephen McMahon, one of the 2 co-founders, and I walked away with a new job, which was great. I joined what was then called the Institute for International Health, which is now the George Institute for Global Health. And this is one of the first publications I saw. This is the first iteration of the Global Burden of Disease study that many of you might have seen. It's published hundreds of articles since the first one, which was really showing the epidemiological transition that was happening around the world. And the leading causes of death were projected in the future to be around cardiometabolic conditions. How am I going with time? Okay? Yeah. Okay, good, thanks. And so this was an area that I was really keen to get involved with, and I had an immediate opportunity, which was a new trial that had just been conceptualized, and I was provided an opportunity to come in at the ground level, and that was the advanced trial that Liz was speaking about. This is still to date the largest trial ever conducted in patients with type 2 diabetes. It was truly global, 20 countries, half of whom came from low and middle income countries, and tested the hypothesis that more intensive blood pressure lowering and more intensive glucose control would improve outcomes in individuals with type 2 diabetes. I was also the beneficiary of incredible academic generosity, which I hope I've been able to emulate in my own career moving forward, in that I became the scientific director, having not conceptualized the idea of this study, and really lead the publications of the main results in the Lancet and the New England Journal. And these findings have truly changed guidelines worldwide and changed how we think about blood pressure lowering, glucose, and diabetes. At the same time, I had the opportunity to pursue PhD studies finally. I decided it was important. It was going to make a difference in my career if I wanted to become a serious researcher. And I did something a little bit different to the advanced trial. I embarked on a series of studies looking at observational data largely, and evaluating the extent to which cardiovascular disease risk factors behave differently in different populations around the world, particularly in the Asia-Pacific region. At this time, again, I got a little bit bored of what I was doing. It's the kind of story of my life. I do get a little bit bored and want to move on to other things. And again, this is a good example, I think, where my clinical work was starting to influence my research focus. Increasingly, I was seeing big treatment gaps. I was seeing patients referred to the clinic, where I was seeing patients who were very high risk and had not been treated with preventative drugs, which are highly effective and safe in the community. This is a study we did a number of years ago, 15 years ago, a cross-sectional study across Australia, which showed even the highest risk patients, fewer than 10% of them were getting the ideal or optimal combination of preventive therapies of blood pressure lowering drugs, statins, and for some individuals, antiplatelet drugs. And this really sparked my interest in what I now focus on from a research perspective, which is implementation science. Again, life changes, and I was offered another opportunity, which brought me to another decision point in my clinician-scientist career. So the George Institute at that stage had offices in Sydney, China, and in India. And director in India had left the role, and my boss asked if I would mind filling in. It was supposed to be for 6 months. Based in Sydney, but I would have to travel a lot, and I realized I could not continue my staff specialist role at RPA with that kind of travel commitment, particularly given I was working quite a bit in the cath lab. So that was a big decision point for me. I had to basically resign from a staff specialist role in order to take this. I could continue clinical work, but I had to reduce it to 1 day a week. Was that enough? Is that going to be enough to maintain my clinical skills, but also enough to continue to provide the value that I get out of clinical work? I decided to take the plunge. 6 months ended up being 4 years. It took us 4 years to find a director, of incredible nephrologist who's a world leader in his area. But I learned a lot. It was an incredible way to get exposed to very different health systems, very different ways of engaging in research, and very different communities. It also triggered my ongoing interest in implementation science, and this evolved in 2 areas, which I'll finish on fairly quickly. This is what work I continue to do. So the first one is around the use of fixed-dose combination therapy for the prevention of cardiometabolic disease. You might have heard the term polypills, cardiovascular polypills. This has been over a decade of work, or 15 years of work, that myself and my colleagues have engaged in across the George Institute, and has really allowed us to engage extensively globally with advocacy policymakers in this country, trials in Australia, India, multiple countries in Europe, and it really now contributed, culminated with this being listed, the atherothrombotic cardiovascular polypill being on the WHO Essential Medicines list, and increasingly becoming commercially available. That work is extended to hypertension. Next week at the European Society of Cardiology meeting, some work that we did in Sri Lanka led to the establishment of George Medicines, which is aiming to bring fixed-dose combination, a very novel fixed-dose combination for the treatment of hypertension to market. FDA regulatory trials just completed and will be announced at a big meeting next week in London. The second area that I pursued was around community health and technology-enabled community care, an initiative called Smart Health with a number of colleagues around the world. This started off in Australia, has expanded to China, India, and Indonesia, scaled up in Indonesia in the Malang district of East Java to a population of 2.5 million. And in Australia, the algorithms from Smart Health are in the Australian government's Health Direct portal. However, I did have to make a big decision 18 months ago that I referred to at the beginning of my presentation, which is when I was appointed to the role of the CEO of the George Institute. And that was to hang up the stethoscope. It was a difficult decision, and at times I still miss the patient interaction, but one of the lessons I've learned personally is you can't do it all. So in finishing, my adventure still continues, and I might use this slide for a bit of a plug about the George Institute. This is an incredible organization, and I have really the great privilege of working with amazing colleagues from around the world in Australia, China, India, UK, and partners across 40 to 50 countries at any given time. And anyone wants to come and speak to me about a career at the George, please do. I hope you don't mind that brief editorial. I'll just finish on 2 slides on a few personal reflections. As I think I've heard you've seen through my journey, there's been a few forks in the road, questions that I've had to ask myself as both a clinician and as a researcher, around compromising my passion. Do I need to subspecialize in an increasingly subspecializing world? Should I do a PhD? What type of clinical work could I do? Giving up a staff specialist appointment is a pretty big decision. And ultimately, is it the right thing to give up part of your career? And finally, sort of separate talk itself, the whole issue about, I don't use the word life-work balance in milk, I think balancing is impossible, but life-work integration. I always get flattered when people ask me for career advice, and I never give it, I just talk about what lessons I've learned. And for me, it was always finding that motivation that led to career changes in the research in my research interest. Being open to change and making the most of opportunities. I've had a lot of luck, but you have to make the most of that luck when it comes your way. I think there are some people who can have it all, can be really active clinicians and top of their scientific fields. I'm not one of them, and so you have to make those decisions sometimes. And finally, a couple of years ago, I think it was International Women's Day, and I was asked what advice would I give to my younger self. And I think my biggest lesson, I've always been ambitious. There's nothing wrong with being ambitious for myself, for my family, for my friends. But while you're maintaining your eyes on that ultimate ambition, remember to enjoy the journey. I don't think I did that as well as I could have. I don't think my younger self would have listened to me because I was very stubborn. But that's the #1 advice I would give to anyone in my situation. Thank you very much.
Thank you so much. That's a wonderful talk. Can I make an appointment for the George Institute next week? It sounds an exciting venture for any of you young people. Perhaps I'll start with a question. Should all of us over the age of 60 be taking the poly pill? No, I think the polypill proponent was, the initial concept of the polypill was just an age threshold. I could give you a lecture here on polypills, but I think for a large number of people who are at high risk, just changing the paradigm of how we approach treatment of individuals, and don't overemphasize the skill of tailoring individual and tinkering individual drugs would benefit lots of people. Thanks. Are there any questions from the audience? Louise.
Hello, Louise Bauer, I'm the president of the Academy, but I wanted, if you could reflect on the issue of doing a PhD while working as a clinician. and how, because you did other research, you worked in a research environment prior to that, you already had a master's degree. How easy or how hard was that? What were the logistics around that? Because I think many people here don't quite understand that.
So I think many people now would have done a PhD, who have a similar career ambition as I do, would have done a PhD earlier than I did. And I was very influenced by people I saw around me who were clinical trialists in cardiovascular disease who didn't have PhDs and seemed to be very successful. But I did still believe that some formal training was important. When I ultimately came to do a PhD, was juggling doing a PhD, clinical work, but also running the advanced trial, which was a fairly big operation. And that made compromises. And the compromises were primarily around the clinical work, but not in terms of the quantity, but the type of clinical work. So in cardiology, being on call all the time and having to go in the middle of the night, it's not conducive to doing a PhD and at the same time running a major international trial. So that's the stage at which I reduced the hospital inpatient time workload and increased my outpatient care, which is more flexible. You could move things around, etc. So there are always compromises, and it's not straightforward. I do think, though, even during my PhD, doing clinical work helped me with my PhD and vice versa.
Anushka, you've had a very international career and a career that's involved a lot of on-call. I know you've got 3 children. Can you, for the young men and women in the audience, can you talk a little bit about that, what you call integration, work-life integration?
Yeah. 2 stepchildren, 2 and stepchildren, and one with us and one no longer with us, both adults. Not having a husband who's a doctor probably helped, and in a different career. So balance. The reason I don't use balance is that it's almost like on a weekly and a monthly basis, thinking about kind of 4 things that I do in my life. I've always approached it this way: there's the family, friends, there's work, and there's other interests, which I think we all have, and it's almost continuously thinking about, well, what are my goals with each, and how do I keep moving that around, and always obviously thinking about not just what I want, but what others that you're interacting with want and need. That hasn't always been easy. I've been very fortunate to have very supportive family, and that's been possible. But everyone's so different. I think one of the things that I've learned very, very quickly, and particularly when people have come to me for advice, is that everyone's life circumstances are so different. And it's very easy to make assumptions about others, and absolutely critically important not to make those assumptions, because you have no idea what's happening in someone else's life. You've just got to make those decisions for yourself.
We've got some questions from the audience. Yes.
Hello, thank you so much for the presentation. My name is Joy, and I'm from the University of Newcastle, working as a researcher and also starting a PhD. But my question again to you, and also will be for the other panelists and speakers, will be, what's your average per week hours that you put into your work?
I don't count. It's a lot, and given that the nature of the work we do, there's lots of evening calls with UK and India and other places where we work. Doesn't stop the very early morning calls with the east coast of the US with the commercial enterprise. But I, again, there's a few things that are getting close to. I'm not giving you a direct answer because I don't want to say how many hours I work. Don't want to put anyone off. But there's 2 things that I make sure I do every day. One thing is exercise. I have to walk the talk. I'm a cardiologist, so I have to make sure I get my daily exercise, which for me is walking. And so that's to get 10,000, nothing magical about 10,000 by the way, but to get 10,000, that's an hour and a half of walking. Not easy to do, so I fit that into the day. So that means sometimes if I've got a 7 a.m. call, I won't get to the office till 10 a.m. Or in the evening. The second thing is just to make sure the family time is put in there. So, you know, that means that I won't do anything on Saturdays. And I'll only maybe do things on Sunday evenings. Yeah, except come to these meetings on Saturdays. Sorry, I deliberately dodged your question.
A lot of hours, but I mean, there is some flexibility when you're a clinician-scientist too. But, you know, they exemplified that by coming in a bit later and making sure you get your exercise. And other questions? Yes.
These sessions are so revealing.
Thank you for your talk today. I'm Hazel Lee from University of Sydney, and I'm a second-year medical student. I just wanted to ask you, when do you think is the best timing to do a PhD?
Again, I don't think there's any one answer to that. But I think if I had to do my time again, maybe with my circumstances, I would have probably done it a little bit earlier. But again, then I was sort of balancing then personal family considerations with the timing of going overseas. For me, going overseas was really important, getting some international exposure. So I don't think there is a perfect timing. I do think a PhD, though, is important if you want a significant research career, which I hadn't believed when I started. I've changed my view on that. It doesn't really matter what the topic is, it can be anything. It's around that real research training, an apprenticeship almost in research that's critically important. But I think it can vary in timing.
I think that question's a bit like when is the best time to have a child. And there's no good time, but there's no bad time, but there's, you know, it's always, it doesn't matter when it is, it's always good. One more question?
Thank you, that was a wonderful talk. My name is Hope, I'm an MD PhD student at the University of Sydney. My question is, I guess when you're starting off clinical training, particularly in those early years, how did you manage, you know, research on the side? Are there any ways that, you know, that you can protect time for research during those earlier years?
Yeah, so I have to confess I didn't engage in much research while I was doing my clinical training. My first publication was a case study as an intern, pneumocystis thyroiditis. I still remember it, I'm very proud of it. But I didn't actually do any research until I'd gone to Boston. And so I didn't have that telemetry training. I know some people are really managing to do that nowadays, and I admire them for that, because I can imagine this is an incredible challenge. Maybe some of our other speakers are doing that, you'll hear about it.
Yes, and for those of you who are med students at the moment, the MD projects now are a great opportunity. So our 3 students from last year have just had 3 publications. So I think just getting that on the board does differentiate you when it comes to the interview stage. Well, I think we'll have to leave there. That's been a fantastic session, Anushka. Thank you very much.